This is being recorded and it'll be posted on YouTube in a week or two. We have really nothing to disclose, and the patient confidentiality is always maintained by changing age, gender, ethnicity, exact laboratory values, etc., to disguise the patient. This is an interesting case today. It's a little different, but we'll have a lot of fun talking about it.
Before we go any further, I want to break in and just say happy birthday, Dr. Rodby. Tomorrow, I think, is your birthday.
Thank you, Steve. I was trying to leave that out. When you get older, you're not as happy to celebrate these things, but that's sweet. Pravir, do you want to read the case for us?
Yeah, give me 1 second. I'll share the PDF so those who can't see it as well, and then we'll go from there. Give me a second here. Oopsies. Actually, I will do that. If anyone has questions, I will share it in a little bit here, but why don't we get started? So we have a 55-year-old Black man who presented initially to an outside hospital a month prior to presenting to us, and he had a history of significant HIV, and he basically came in with shortness of breath, was diagnosed to have a pneumonia. During that course at the outside hospital, he was incidentally found to have thrombocytopenia, and he was started on high-dose steroids, 100 milligrams a day, and the thought was that this was ITP. Now, the records that we received were incomplete, as sometimes they are, and he didn't really have a good baseline prior to this. He was following with his infectious disease doctors, but we weren't really able to get the full records. And during that admission, his pneumonia symptoms improved, but he really did not have improvement of his thrombocytopenia. He was sent home on high-dose steroids with follow-up. And about a month after discharge, he presented to our hospital, and he came back through the emergency room because he noticed about a week history of diplopia, ptosis, and now a 30-pound weight loss. So on arrival to the emergency room, he was febrile, as fever was up to 102 Fahrenheit. He had now a new AKI. Well, we don't know what his prior baseline is, but he had elevated creatinine, I should say, of 1.9 milligrams per deciliter. His glucose was 800, his albumin was 2.1, and his hemoglobin was 9.8. Platelet count was still low, 34. He was seen by our neurology team, and his symptoms of diplopia were thought to be due to a cranial nerve 3 palsy that was precipitated by the high-dose steroids. He underwent pan-CT imaging, given the lack of a source for his fevers, especially with high-dose steroids, and they were found to have multiple enlarged lymph nodes, and he had hepatosplenomegaly. He continued to be febrile, and so blood cultures, everything was negative. He underwent respiratory panel. This was during the time of COVID. His COVID was negative. He was placed on cefepime and vancomycin. His further workup showed that his LDH was 450, which ferritin was 5,000, elevated uric acid of 11, and his haptoglobin was high, 225. His bilirubin was mildly elevated at 1.5, and his fibrinogen was high at 850. He was started on IV fluids, and his creatinine initially came down, but then it started to trend up. He was non-oliguric, and you can see here, the creatinine initially kind of went down with the fluids, but then started to go up. And each vertical line, as depicted there, represents a day. So this is going up over the course of now, this is a week, 2 weeks. A week. Each one is a day. Let's see if I can, oops. Let's see, there we go. Other workup, his urinalysis showed trace blood, protein on dipstick. He only had 3 RBCs, 1 WC, and a UAC of 0.1 gram per gram with a corresponding urine protein creatinine ratio of 1 gram per gram. His serological workup was sent off given his AKI and his UPC and UAC discrepancy. He had which we'll get to. He did have a bone marrow biopsy done as well that showed a plasma cell neoplasm involving 8% of his cells. His renal function continued to deteriorate, and he eventually had to start dialysis. He was given respiricase, given the concern for acute uric acid nephropathy with his AKI and uric acid, which was still uptrending up to 12. He had a lymph node biopsy done that showed reactive tissue only. His platelets did finally improve to 100K, but he still had no other signs of renal recovery, so we pursued a kidney biopsy. In terms of his past medical history, he had a history of the new thrombocytopenia that had gone on for about a month. He had a history of longstanding HIV, which was controlled based on the information we were provided, and he was on therapy for that. Non-smoker, no drinking, no drug use, no family history of kidney disease. His HIV medication is listed there. There had been no changes in those. His prednisone was 100 milligrams per day when he presented to our hospital, and he was on PPI prophylaxis, given high dose steroids. Review of systems, as I mentioned initially, nothing else. On exam, he was febrile, but his blood pressure was stable at 126/80. He was tachycardic at 120. BMI of 23. On exam, really, he was, nothing too much to note of outside of his cranial nerve 3, signs. He didn't have any extremity edema. He didn't have any redness, swelling, no easy bruising, nothing of that sort. He had some mild high frequency tremor that was noted by the neurologist. And again, they thought this was all related to this high dose steroids. In terms of his laboratory data, his sodium was 142, potassium 4.5, chloride 105, bicarb 26, BUN 76. His creatinine had gone up to 4.3, and these are labs at the time of the biopsy, when his platelets had improved closer to 100. His glucose is finally controlled at 120. His total protein was 6.1 with the albumin of 1.5. Bilirubin was mildly elevated at 1.6. Alk-Phos mildly elevated at 160, but his AST, LT were normal. His white count was 5.75 with the diff listed as listed, nothing too off of the normal. Hemoglobin was 7.0, platelets had improved to 90. His INR is 1.35, and his PT and PTT were relatively normal. His serological workup, as I mentioned, we had obtained. His PR3 was elevated at 25.1, MPO was negative. His C3 was slightly low at 79, and C4 was slightly low at 9. His SPEP and UPEP did not show any monoclonal proteins. He had a kappa lambda ratio of 0.52. Microbiology workup, his COVID was negative. Parvovirus PCR was negative. His HIV RNA quant was 122. His EBV viral load was 16, should be 169,000. His CMV was less than 300, and his herpes virus 8 DNA was extremely elevated. His UA, as I mentioned before, had some trace bloods, trace protein, no 3 RBCs with the UPC of 1 gram per gram with the corresponding UAC of 0.16. His kidney ultrasound showed 2 kidneys without hydronephrosis, the left kidney of 4.4 centimeters and right kidney of 13.3 centimeters, and the kidney biopsy was performed.
Great. Any questions? We have a question about a cryo. Cryo was not performed.
The plasma cell neoplasm was it B cells, lymphoma? Was it myeloma? What was it exactly? I mean, do we have that information, or it was pending at the time of biopsy?
Still pending at the time of biopsy. They had done that given the lymph nodes. It was extremely difficult to do a lot because his platelets were low, but didn't have that information at the time of the biopsy.
Great. Before we open it up to discussion, I want to run a poll. Normally, I don't have 7 things in a poll. I think it's a ridiculous thing to do, but it's kind of a lot of possibilities here if you look at the case. And so I put a lot of options in the poll. So what do you think the primary cause of this patient's AKI is? Plasma cell infiltration of the kidney. He's got this plasma collection in his bone marrow, lymphocyte cell infiltration of his kidney with or without EOs, some question of maybe lymphoma or interstitial nephritis, a monoclonal gammopathy of renal significance, acute tubular necrosis, renal vasculitis, is a positive PR3, either vascular or glomerular, an HIV-associated nephropathy, or even acute uric acid nephropathy. Give it a little time. Please vote. It's all anonymous.
Give it a few more seconds here. Pretty good. All right.
Tell you, there's a pretty complete smattering here, a little bit of everything. One from every column.
So we can share the results here.
So we've got a lot of 10, 20%, and it's pretty well spread out. The two biggest by far is ATN and monoclonal gammopathy of renal significance. And a vasculitis comes in third, and everyone else is about 10%. So, I mean, it does actually tell us why we do biopsies and gives us kind of a broad differential diagnosis. So, Bill, Dr. Whittier, can you discuss this case and try to, maybe we keep this poll up and you can kind of go through what the pros and cons of each of these?
Sure. Maybe I'll start with what was most common, which is ATN, which is if you step back and you look at ATN, I mean, his renal failure occurred in the hospital. He's a very sick person, has a lot of things going on, and his urinalysis is consistent with that. So if you just start there and keep it that simple, it's ATN. But we don't biopsy for ATN typically, and there's so much else going on here that this person clearly needed a biopsy. The monoclonal gammopathy of renal significance, I don't remember him actually having a monoclonal gammopathy, but I think what we're getting at there is that he had, and maybe I missed it, but I think what we're getting at is he has a plasma cell dyscrasia of some sort. And so there's possibly some sort of infiltration from that, or the like a chloroma, like an actually infiltration into the kidney, or there could be something, depositing there from whatever these cells are that are being produced. So I think that's there too.
Yeah, and as you well know, I mean, certainly many plasma cell dyscrasias don't have anything in the blood or the urine. They were negative in the blood and the urine, but this was found in the serum, which kind of brings up the possibility of option 1 and option 3.
Yeah, you mean it was found on the bone marrow biopsy? Is that what you're saying?
That's what I meant. Yes.
Yeah, right. Exactly. Right. So, right. I think those are still there in the differential. When I was initially thinking about the case, I was sort of thinking, is it ATN if I just keep it really simple, or is it something associated with these other diseases? And, the first disease that was described in the case really that he has was his significant HIV when he comes in with thrombocytopenia. And so the HIV differential is very wide, and we think about high VAN, which I think is not really in this case because he doesn't have that much proteinuria. Maybe high VIC. He certainly has some immune complex looking stuff in his blood. His complements are low. He's got a positive PR3. He could have that. He had a little hematuria, if I remember.
Bill, could you say what high VIC is?
Oh, so, yeah, sorry. It's basically an immune complex disease associated with HIV, almost like a lupus-like syndrome. Maybe like a lupus HIV overlap is kind of how I think about it, where you have an immune complex sort of deposits in the kidney. But more often what we're seeing, more commonly in the modern HIV era is medication side effects from HIV. Classically, there'd be tenofovir or one of those. And I didn't see tenofovir on his list, but I didn't go through his list and look up all of his medicines. But anytime there's medicines I don't know the names of, I'd have to look them up to see if they're associated with ATN or what have you. And then we throw this significant thrombocytopenia into there. Is that because of his plasma cell issues that he's thrombocytopenic, or does he have a TMA, thrombotic microangiopathy? And those are also associated with HIV. And so he could have something there. So pretty wide differential. And then he comes back to the hospital. He's got a one nerve that's affected, and he has a 30-pound weight loss. To me, if I hear a mononeuritis multiplex with a 30-pound weight loss with AKI in the setting of a PR3 that's positive, you'd have to be crazy not to put PR3 vasculitis up there in the differential too. So, and I'm not sure that a classic mononeuritis multiplex is a foot drop or something like that, but this is one nerve that's affected. Now, Pravir, I think you had said that neurology thought that this was due to high dose steroids, and honestly, I'd have to believe what neurology says there, but it certainly would be in the back of my mind, especially when I saw this PR3 come back positive, that wow, we really do not want to miss a vasculitis and blame it all on ATN here. So I hope I've kind of hit most of them. Oh, acute uric acid nephropathy there. I mean, kind of a tumor-like syndrome. His uric acid was high, but I don't know. He wasn't really hyperkalemic, at least it wasn't on these labs. I don't know if, I don't think about tumor lysis without significant hyperkalemia. Of course, it can be uric acid nephropathy or the calcium phosphorus deposition, but I think that's probably a lot less likely. His uric acid wasn't super high, if I remember right. So anyway, if I had to pick number one, global thing, I would think ATN, sick guy, urine fits that, he's in the hospital. I'd be really worried about a PR3 vasculitis. I would also be worried about high Vic.
What about number two?
Yeah, sorry. I even wrote down on my paper here, big kidneys, and then I wrote down, well, you can get big kidneys with HIV, but you could also get big kidneys with a lymphoma infiltration, or I mean, I think they can call it chloroma if it's with leukemia, or lymphocytic cell infiltration, and that can be with renal failure without a lot of significant urine findings. So I think that's in the differential too. He's got big kidneys. I think if I remember, they were 14 centimeters.
Yeah, 14 and 13, yeah.
So I don't remember seeing what his size was, but that seemed a little big in my mind too. So that's definitely in the differential also. His renal failure seems a little more abrupt, like an ATN as opposed to an infiltrative process. And it's also hard for me to imagine that someone would infiltrate acutely while on such high dose steroids, which should treat most lymphomas. But still, it's possible.
I think that's a good point. I mean, you have to consider what is happening in the setting of all these steroids, and some of these things may or may not be as, he's been on steroids for a few weeks now, and he just continues to get worse. Dr. Gashty, what are your thoughts?
I think Bill really did a beautiful job discussing the differential. The couple things that I guess we should focus on is this whole discrepancy between the protein creatinine ratio, albumin creatinine ratio, pointing a little bit more towards the tubular interstitial process because there's really no albuminuria. So I'm thinking this is probably tubular interstitial in nature. And this is a really sick patient that came in with all these abnormal lymph nodes and thrombocytopenia and plasma cells in the bone marrow. And so I have to believe that there is a relationship between this systemic potentially blood cancer and what's going on in the kidneys. And maybe the PR3 is a red herring. It just doesn't seem like on 100 of prednisone that this patient would still blow up like this. So, interstitial nephritis, typical stuff that usually responds to steroids, seem less likely because of the fact that he's being treated and he's still getting worse. So I'm sort of in favor of the top of the list here, where you could either have direct invasion of the kidney with the plasma cells, or you have, some kind of a lymphocyte, like either plasma cell or lymphocytic infiltration. Monoclonality, I feel like, as you said, you can not find monoclonals in the blood, and you can actually have like MGRS, if you, have low enough limit of detection of the light chains. ATN is always a possibility. I mean, statistically, that's probably the highest percentage, highest yield answer here. Everybody gets a little bit of ATN on their biopsy, whether that's really the cause of the AKI or not, it's kind of to be seen. So I think Bill covered it pretty well, but I think this is going to be tubular interstitial in nature. So it's ATN versus, we're going to see some infiltration of the cells inside of the kidney, and that would be sort of tubular destruction and cause of the AKI. That's kind of where my money is at.
Casey, we have a little more of a mixed audience today. Can you just explain the protein creatinine ratio, albumin creatinine ratio?
Sure. So we usually think of albuminuria being sort of the glomerular proteinuria, and in this particular case, most of the time when we have glomerular proteinuria, the ratio of albumin to total protein in the urine would resemble the blood. So it would be, 60%, 50% or above. In fact, in some nephrotic syndromes like minimal change disease we discussed a couple of weeks ago, it could be 90% of the total protein in the urine would be albumin, selective albuminuria. So if we see that the albumin creatinine ratio is such a smaller percentage of the total protein in the urine, we think of there's a non-albumin protein in the urine, and usually that's something smaller like a beta 2 or a some other protein like a paraprotein that could end up in the urine and kind of throw off that ratio. So basically this is about a 15% of the total protein in the urine is albumin, whereas in the blood it's almost 50%. So I'm thinking this is probably a non-albumin proteinuria pointing towards tubular interstitial process.
Yeah, thank you. Bill, you made my day when you said mononeuritis multiplex, because it's not a term that we often use in nephrology because it's typically a large vessel vasculitis that does it. I remember learning that as a second-year medical student, and the first vasculitis case I ever saw was Church-Strauss, which I don't think I've seen but one since, and exactly presented with a foot drop. My impression, though, I know that small vessel vasculitis doesn't typically do that, and I'm so glad you brought that up in the differential diagnosis. It seems to be those kind of larger vessel vascularities are more common with like polyarteritis nodosum, even though you're absolutely right for bringing it up, and those tend to be ANCA negative. But this ANCA is pretty interesting. Of course, though, it doesn't fit the urinalysis, but that's why in the poll I put either vascular or glomerular, because you certainly could have a vasculitis of small vessels, that preglomerular vessels, and not necessarily have any proteinuria hematuria and still have a vasculitis related GN or renal disease rather. There's lots of really good comments. I'm not going to talk about any of these in the chat because we're going to get to that eventually. Anybody else have? Yeah, Dick, take it over.
Well, I just wanted to make a small point, is that biopsy series in patients with HIV who have kidney disease are notable for the complete absence of vasculitis as a cause of their kidney disease. So I know the patient's PR3 is positive, and the patient does have a neuropathy, or at least has evidence of a neuropathy, and that raises the possibility of a vasculitis. But I think the rarity of vasculitis in HIV is notable. And looking over the lab work, I must say I would be thinking of the possibility of a multicentric Castleman's disease, which can produce a lot of abnormalities in the laboratory, like this patient. And there is a subvariant of that called the Tafro syndrome that is associated with severe thrombocytopenia and progressive kidney disease. So I would add multicentric Castleman's disease and the Tafro syndrome to the long list of differential diagnosis.
I think that's helpful. Thanks. And I know that's been in there along with an EBV related. I'm talking from the chat chain. Two people had mentioned Castleman's, EBV related lymphoma, IgG4 related disease, HIV associated lymphoma. Because in the end, what we really haven't talked about is, and we're going to move on, but we haven't really talked about what the heck's going on with this guy. He's got weight loss, he's got lymph nodes, he's got a lot of stuff going on. That may help you, and I think that's kind of where one of the things Dr. Glassick is looking at the broad picture here. So I think we've got a broad differential. We've got a lot of different pathology possibilities here. I think that it's time for us to look at the biopsy.
In Castleman's, the renal failure would be more infiltrate. I mean, it's a sort of a lymphoma with HIV or with human herpes virus 6, I think, if I remember. So is it interstitial nephritis and ATN? Is that what we're thinking, or is it if he does have Castleman's?
I looked this up a while ago, and it's apparently extremely unusual to affect the kidney. That Castleman involvement in the kidney is highly unusual, even though it's a often a multicentric disease. But all right, let's spin the wheel. Don't worry, candidates, interview candidates, you're not on the wheel.
Oh, we scratched that plan? I thought we were going to keep him on the wheel.
Yeah, I changed my mind at the last second. Didn't want to send the wrong message. All right, Dr. Gashty.
Give me a second, Casey. And I'm going to give you.
Dr. Gashty is one of our faculty.
Go ahead and click on the screen. Yep, you're controlling, and you should be see the arrows on the bottom.
Also our onconephrologist, and so this is really right up his alley.
That's a really good point.
Right, did that already. All right, so here's a high power trichrome. We're looking for the blue staining material, which is kind of rare here. I think this is actually a good looking biopsy. There's not a lot of chronic fibrosis.
Yeah, I agree with that.
Just one thing. All right. So I would say, I think in general, maybe 10–15% altogether.
Yeah, pretty minimal.
Okay. All right. Here's a high power H&E. You can already see that there's this interstitial infiltrate that's around this glomerulus and surrounding the tubules. We can probably see what kind of cells they are at a higher power, but yeah, I think they're too small for me to comment on it now.
Okay.
The glomerulus itself, I think I want to see a few more glomeruli, because this one, the tuft looks a little bit more like pulled away from the Bowman space. I don't know if that's just an artifact or it's actually like a little ischemic, but I'll just wait and see a few more. But it doesn't look silly. It doesn't look hypercellular. There's no crescent. I don't see any focal areas of necrosis or collapse or anything like that. So the glomerulus looks normal. The tubules do have some ATN. I see some sloughing of the brush border, few casts, not casts, but some just material inside of the tubular lumen. But the predominant abnormal finding on this slide is the infiltration of these cells inside of the kidney.
Yes, I
I'm
agree.
looking for, casts, cast nephropathy, since there was plasma cells in the bone marrow. I do not see that.
Okay, great.
Here's a higher power H&E again, and looking at this glomerulus, the capillary loops are open. It does actually look a little hypercellular. The mesangium is maybe just mildly expanded. I think there are some areas where I see maybe 5 or 6 cells. So maybe mesangial hypercellularity, maybe mild expansion, but maybe I'm just overreading that. But again, there's nothing proliferative and nothing crescentic. There is this periglomerular infiltrate. I do see some plasma cells because I see some cytoplasm. I'm pointing to one here.
Yeah.
Am I correct? Is that a plasma cell?
Yeah. Very good pickup.
And then I don't see any eosinophils at this point, and there's some loss of bush border here in this proximal tubule. So there's some ATN so far, and there's some interstitial infiltrate with plasma cells.
Yes, yeah. Predominantly a mixture of lymphocytes and plasma cells, like you said.
Okay. All right. Here is another glomerulus kind of hanging off the edge here. Similar features. There is some mesangial expansion, but capillary loops are open. Definitely see the same mixture. I see more plasma cells here. Here's a good one right here. And then there's some lymphocytes. So mixture, and there's some red cells inside of the tubule.
Yeah.
And other than that, here's an arteriole.
Yeah.
Looks fine.
Yeah, no thrombus.
No thrombus in there because TMA came up. So yeah, so far, again, just ATN and interstitial infiltrate.
Yep.
Here's a PAS stain of one glomerulus. Looks good. Actually, the mesangial expansion isn't even really that significant. Maybe a little bit out here. So I would say mild. And then surrounding tubules, I see some brush border here. Maybe some focal loss of brush border, but for the most part, this looks pretty good. And then some cells infiltrate, interstitial infiltrate here at 2 o'clock.
Yep, great.
Here's a Jones or PAS stain. we are looking at the basement membrane, and it looks very nice and thin and delicate. I don't see anything, I don't see any breaks. I don't see any spikes or holes. I wasn't really expecting breaks because on the other light stains, we didn't really notice any proliferative lesion, but at least maybe if we're concerned about a membranous, I don't see any humps or any, not humps, I'm sorry, I don't see any spikes. Here's a closer up of that interstitial infiltrate. Definitely a lot of plasma cells. So there's a plasma cell, there's a plasma cell. These are all plasma cells, which have a bigger cytoplasm nucleus ratio as opposed to these lymphocytes, which have this much darker nucleus and bigger nucleus compared to the plasma cells. So yeah, lymphoplasmacytic, I guess, is a combined infiltrate.
Yeah. And then there's an arterial there at 3 o'clock that looks normal.
Yeah, it looks normal. I don't see any eosinophils.
Yeah, there were no eosinophils and infiltrates.
Okay. All right. Here's something that's inside of this tubule. So there's a cast in here. I'm assuming this is a granular cast.
Yeah, it looks like
Right, David?
necrotic epithelium.
Yeah, I mean, it looks, I mean, if you look at the lines, you almost can mistaken this for like a calcipropathy. Calcipropathy, but I think that you can see the lines also like inside of the cell. So I think that's just an artifact. And also there's cells, there's nuclei.
Yeah.
So I think this is a granular cast.
Yep.
Both of these are granular casts. And here's a distal tubule here with all the nuclei lined up nicely. And I don't see any no abnormalities here. So this is ATN with granular cast.
Yeah.
Kind of more of the same. Here's a nice cut of this long tubule. Half of these tubular epithelial cells have sloughed off already, and the rest are about to. Here, same thing, thinning of the epithelium, loss of brush border. I'm not sure what this area here is. It looks just scarred.
I think we're coming up on an artery. It's longitudinally cut. We don't see the lumen yet.
The way it's cut. Okay.
Yeah.
All right. So basically, this still supports ATN.
Yeah.
But I think, I guess if I look at the bigger core, the interstitial infiltrates seem very small and patchy.
Yeah.
I think the cause of the creatinine elevation is ATN. And I mean, we still have to address the plasmacytic infiltrate. Here's a mitotic figure. So there is some regeneration from ATN. Yep. And again, you can see some of these hydropic changes in the tubular epithelial cells right around here. IgG is negative.
Yeah, there wasn't an EM sample. I did want to rule out that there wasn't a neoplasm of the infiltrate. So I did kappa lambda, CD3 and 20, and it was a reactive mixed population.
What about IgG4?
Since it was also since it was plasma cell rich, I also did IgG4, and there was no evidence of that disease.
Okay, so right now we have.
David, this kappa lambda, everything, those were all, there's no restriction, right?
No.
Okay.
Casey, you were saying?
So the diagnosis is ATN plus acute interstitial nephritis, but it seems kind of focal and patchy.
Yeah.
So David, we were burned before. Did you do a pronase?
No.
No, there was no positivity on the immunofluorescence.
Right, but you still could have a hidden antigen there.
That's true, but no, we did not send this one off.
Okay.
It's a good question, and I know that pronase is now being expanded to a lot of different scenarios, but sometimes it's hidden within a capital lambda, and sometimes it's hidden within nothing, and but no, it was not done here. I think it's a good point. The fact that the plasma cells didn't at least appear monoclonal is a little against that, but no, I mean it's still a good point. So look at everybody here. Nice audience. Moving on, before I discuss, kind of the punchline of this case, anybody have any more thoughts? Dr. Glassick was putting out Castleman's. We had Dr. Friedman, Dr. Penasumi, and Dr. Glassick all piping in for Castleman's. We've got some lymphoma votes, some plasmacytoma votes. Anybody have any, lymphoma, I think still has to be somewhere in that differential. And the guy's clearly presenting with a multi-system disease, weight loss. The platelets are odd, unless it's that variant that was mentioned by Dr. Glassick. Anybody else have any other out of the clear diagnoses? If not, I'll move on. I'll tell you.
Yeah, I mean, it's, putting it all together, like you say, it seems like he is presenting with a pretty bad lymphoma, and he was sick enough to get ATN. I don't really know if we're clear on what the cause of the ATN was. I mean, I don't think he was on any medications that can cause it. From the history, he didn't get anything that was precipitated.
He's on that tenofovir, right? He's that one of his HIV
is
drugs has tenofovir in it.
He has tenofovir, yes.
Oh, he is. Okay.
And it's not the alafenamide, right? This is the nephrotoxic one, not the less nephrotoxic one.
I believe.
Alafenamide is the safe one.
Is the safe one, right?
Yeah, the diazoxyl fumarate is the older one that's nephrotoxic. So he was on the new one.
He's on the new one. Okay.
It'd be worth.
What about the vancomycin? Was that wasn't a factor here? I know he was on the bank, I thought at one point.
Yeah, that was started. He had already presented with AKI, so we can't really blame that. It could have.
Well, we don't know. I mean, that's a good point,
added.
Steve.
Yeah.
That's a good point, Steve. He came in with a creatinine of 1.9. It got a little bit better. We're calling him AKI. We don't really know what this guy's baseline is. We just know that, what the graph showed very early in the course of that, he started climbing in the hospital, but he was also very sick in the hospital. And he was getting, he came in with fever and he was ill. And, everybody ordered every test known to man. And a lot of them came back positive. But, it's hard to sit on somebody like that and not give antibiotics. So he did receive vancomycin and cefepime for quite a while. So I don't think that's, out of the question. And certainly, vancomycin's now been sometimes reported to show vancomycin casts, but not universally. And we don't know if that's the chicken or the egg when we see that in there. But I think that's, and it's also more associated with vancomycin. But still, I mean, I think that's always a possibility. I think Casey's point's really good, though. He was on a PPI and he was on a cephalosporin, and there was a little bit of interstitial nephritis, but I still think the major renal lesion here is ATN. I'm sorry.
No, Roger, I was going to ask, in view of these positive viral studies, were proper stainings done in the kidney for those?
I do not think so. Really good point. Now that's a transplant nephrologist thinking for you.
Well,
Touché.
when you have a plasma cell infiltrate, the differential is broad. It could be a drug-induced problem. It could be a PTLD in terms of transplant. It could be a viral infection. It could be IgG4, and that's pretty much your differential. But in this case, I wonder whether viral stainings are appropriate.
I don't know if they're appropriate or not. I know we didn't ask for them. David, is that something you can do typically?
Stain for what? What's he asking for?
For various viruses in the kidney, specifically.
There's a CMV stain. There's a polyoma stain, adenovirus, herpes. Those are the virus that we could stain for in tissue.
Mm-hmm. No, I think that's a really good point, Mario. I think that's a good point. We didn't really even think about it at the time. If we could just move on, about 15 minutes left here. So hospital day 5 and 6, he was transferred to the MICU where he started getting transfusions of both platelets and blood, and he was also hypotensive. He was started on respiricase because the primary team was fairly convinced he had tumor lysis syndrome. I only threw that in there as an option in the test because that's really when we got consulted. We were consulted for tumor lysis syndrome. I'll show you what his response to his uric acid was. But, I think that's kind of an unusual diagnosis to make with a uric acid of about 11. He was put on continuous renal replacement therapy. He started receiving a cyclic or possible meningoencephalitis. Hospital day 8 to 4. So this is a long hospitalization. He finally had a lymph node biopsy. It was non-diagnostic. He got sicker. He became anuric. Again, more CSF studies. All were negative. They repeated a lymph node biopsy. Same thing. Just reactivity. No specific diagnosis made, at least at that time. Hospital day 21 to 32. He finally comes off dialysis. He goes over to rehab, and he's sitting over there in rehab, off dialysis, on steroids without a diagnosis. Hospital day 40 now comes along. His platelets drop again to 19,000. Hematology is reconsulted. They go back and look at everything very closely, and bingo, they felt this was consistent with the plasma cell variant of Castleman's disease. I applaud the three of you that brought that up. And it was consistent with multicentric Castleman's disease. Castleman's disease can be unicentric, which is just a single lymph node area or organ, but clearly he had splenomegaly and he had hepatomegaly and multiple lymph nodes, and so that would define it as multicentric Castleman's disease. Now, I'm not going to try to explain Castleman's disease. I'm not sure the hematologist can tell us exactly what it is, other than it's a lymphoproliferative disorder that's thought to have different possible mechanisms to get there. Autoimmune, malignancy, and infection. And if you look at him, I mean, his PR3 was positive, and that's probably a red herring. But you know, having HIV, there's an HIV-associated infection. Although, you know, Dr. Glassick brought up the point that vasculitis is very unusual in someone who has HIV. But his HIV, yes, he has HIV, but I assume it's unusual because they're so immunocompromised. And actually, from the standpoint of his CD count, blanking on which one it is for HIV, but it was actually pretty normal, and his viral load was very low. So he's really because he's on double and he's very compliant with his heart therapy. He really was doing well. Having said that, he clearly had high viral titers of both EBV and human herpes virus. So it wasn't as though he was completely immunocompetent, I would guess. But regardless, he had both of those infections, both EB and especially human herpes virus. And these are also somehow related to the causality of multicentric Castleman's disease. So what are the consensus criteria? And by the way, when you have a Venn diagram that this complicated as the one before, it tells you don't really completely understand a disease. But they have major and minor criteria, which you always have when you have a difficulty making a diagnosis. These are present for a lot of diseases. You know, we all know it quite well for lupus. But sometimes you don't need criteria. You know when it's lupus. But what they require for major criteria is histopathological lymph nodes, which was apparently there but not recognized, and enlarged lymph nodes in greater than 2 stations. He clearly had that, and then a number of other things: thrombocytopenia, renal dysfunction, proteinuria. It is interesting that he did have tubular proteinuria with his primary renal lesion being ATN. Although I'm not sure we always look at the nature of the proteinuria in patients with ATN to see how non-selective or selective it is. Hypoalbuminemia, I think a lot of this just reflects being ill. He certainly had the constitutional symptoms. He had fever and weight loss. He had a large liver. And then of course all these lymph nodes with the biopsy. And if I could show the next slide here, maybe David can describe this, but this is what's somewhat described as fairly typical for Castleman's disease. David?
I mean, that is crazy. That is really crazy looking.
Well, then you should describe it. No, David, could you describe this?
It looks like we have a lymph node biopsy. In the center is a mantle zone or germinal center surrounded by lymphocytes arranged in layers.
Yeah, and I think the layers are really impressive here. You know, I've seen the pictures of IgG4 related disease, which of course is plasma cells in a spindle kind of picture. There's another palisade. Yeah, there's another term for it too, but which I'm hardly convinced that I ever see that. It almost looks like storiform,
I think.
Yeah, storiform, exactly. Thanks, David. But I always have to imagine seeing it. Here you can clearly see the layers that are described in this, and with the cute little lollipop in the middle. This is not him, by the way. This is just what's described pathologically. And I don't really want to go over this, but basically, in clinically multicentric Castleman's disease, you kind of break it down into different categories. But the diseases to exclude are the infections, the autoimmune diseases, cancers, lymphoma, etc. If you go far to the right, you have HHV8, which is human herpes virus 8 related disease, and I think that's what they really were thinking about in this disease, because as Dr. Baxi said, his numbers, his copies were off the chart high, and then you pretty much break it down from that point into HIV positive, HIV negative related HHV related multicentric Castleman's disease, and they break it down the treatment into whether it's idiopathic or it's related to HHV8 or HIV, both of which he had. Although it's interesting, I still make the point that he's HIV positive, but he really doesn't have active HIV disease right now. So, but I don't think I'm not an infectious disease person to be sophisticated enough to say if that matters, if your HIV viral count is normal, that you have no immunocompromise at all. And what role does that play in having high EBV and high HHV viral counts? I'd be interested if anybody knows that. But it certainly, that puts us into the category to the right, for which the treatment, therefore, is antiretroviral therapy. He's already on antiretroviral therapy, rituximab, or topicide, and then you consider antiviral therapy, etc. So here's a graph of initially what I put together, because this case was presented to us as tumor lysis syndrome, which really didn't fit. His LDH wasn't high. He didn't have the other signs of that. His uric acid was, yes, it was 12, but I've never seen it close to the lower graph is the uric acid, the upper graph is the creatinine, and I really haven't seen that kind of uric acid nephropathy with uric acids in the low 10, 11, 12. Typically it needs to be closer to 20. But they gave him respiricase, and you can see two things happened. His uric acid dropped precipitously because it's absolutely a magical drug. And his creatinine came down, but he was also being dialyzed, so you can't say anything about that. Eventually, he got his renal biopsy, which diagnosed his ATN, and at one point his dialysis was stopped, but he got sick again, and it went back up very precipitously again, and dialysis was reinitiated. But eventually, dialysis was discontinued. And in fact, you can see his creatinine came down to a remarkable under 1, which is kind of amazing considering he was dialysis dependent as long as he was and as bad as his disease was. But we all know what ATN can do. And we always have to remind the residents, this is an unusually disease that would lead to prolonged or not unusual to have CKD, but to have ESRD. Next slide. So really, what he got was once the renal biopsy was done, and then he got the second lymph node biopsy, and then it was really only when he was sitting in a rehab center, he dropped his platelets, that heme got more involved. And I don't know exactly, was it a new attending? Was it they just went back and looked? I don't know, but they clearly someone put it all together as Castleman's disease, and he started rituximab. Realized he's also getting antiviral therapy, and he's on acyclovir. And sure enough, it was pretty clear what happened from that point on. He felt better, his fevers went away, and his renal failure got better. He had a real nice diuresis, and he's doing quite well with rituximab. I don't know if there's maintenance therapy is going to be required for this or not. I don't know if that's based on his viral count. There's a lot of nuances that a hematologist could tell us, but I have to tell you that although this is a case of just ATN, I think it's a fascinating CPC. And again, I applaud the people that were able to think through it and come up with a diagnosis. I have about 5 minutes left, and then I'll open it up for general discussion. But I want to talk about the renal syndromes associated with HIV. That is kind of irrelevant to this case, mostly because he didn't have many of these presentations. But I think it's worth reviewing for the generalized audience. Of course, there's glomerulonephritis, there's HIV-IN, which is collapsing FSGS. It appears to be related to both genetic and viral components, the viral, of course, being the HIV virus, but genetic components, it's much more likely in people who have too high risk APOL1 variants, as is the case with most collapsing FSGS and viral, be it parvovirus or other. Dr. Whittier mentioned HIVAC, associated immune complex disease. That is seen occasionally. We don't completely understand it, but it's also in the differential of GN associated with in patients with. These are both pretty much, if you have active HIV, they're not typically seen when your viral counts are as low as him. It was also brought up heart therapy, and tenofovir was a big drug that caused a lot of renal failure back when the initial drug, fumarate, disoproxyl fumarate was the only one available. It was a prodrug, and because it was a prodrug, you had to give 10 times the dose of the newer one, which is alafenamide. And so we don't really see renal failure much with alafenamide, but it gave a lot of proximal tubular damage, not only AKI and CKD, but we saw awful Fanconi syndrome associated with it. I remember a case we had with hypophosphatemia and rhabdo and nephrogenic DI, maybe from hypokalemia or maybe also just tubular damage. Really remarkable case several years ago. And that was actually, believe it or not, on alafenamide, and we reported that case. Lactic acidosis is seen with all heart therapy as they can affect mitochondrial function. And then, of course, you have to remember that this crystal-induced AKI, and indinavir was the one that was early described. These are the crystals. We don't see that. We don't see it in indinavir used as much. Darunavir, which is what he was taking, was part of his other drug than his Genovia, Genvoya or whatever. But we didn't see crystals in his kidney, and we certainly didn't see crystals in his urine. And acute interstitial nephritis, I mean, they're certainly prone to that for a lot of reasons. He was on a PPI and antibiotics, but in the end, this was all about ATN for him. And it tells us two things about that. One is that ATN will usually get better, and thankfully, thankfully for him, he got thrombocytopenic, and the diagnosis was finally made. I'd like to open it up to anyone else's discussion.
Roger?
Yes, Dick.
Yeah, great case. And I wonder if electron microscopy was done in this case, because multicentric Castleman disease is associated with a tremendous elevation in VEGF in the serum, probably due to marked endothelial injury. And, marked endothelial injury can produce AKI. We see it in toxemia pregnancy, and I just want to be sure that this patient doesn't have endotheliosis, which would require an EM to really look at it.
And would you see that without any without any proteinuria?
Well, I'm not sure. It depends how far the GFR is lowered in the patient. I mean, if you lose all glomerular function and you're oliguric, I don't think proteinuria is going to be a very reliable sign. But
no, I think that's right. And
I'm just asking because multicentric Castleman disease is characteristically a high VEGF disease.
And that often leads, that's just basically endotheliosis or TMA. Right. And
do we have EM in this case?
David?
No, we didn't have any glomeruli for the EM sample.
That's too bad. Okay.
Yeah, that's a really, really good point, Dick, though. This is an older case, and when Dave sent me the slides, there was no EM, but I didn't remember exactly why. Yeah, that would be really, really interesting to see if there was anything going on. I mean, certainly that is a bloodless glomerulus, and the light didn't really imply that there was endotheliosis, but it would have been really nice to look at the podocytes.
It's usually with endotheliosis and the VEGF. I thought it was anti-VEGF, meaning like it was the S-flit that was impairing the VEGF, and in the Avastin cases, it's anti-VEGF that leads to endotheliosis. So aren't typically in the preeclampsia patients, aren't the VEGF and the placental growth factors are quite low? Is there an inhibitory factor to VEGF that's really high in Castleman's, or is it actually just VEGF?
Well, I think VEGF elevation in Castleman's is thought to be a part of the endothelial injury, which is seen in this disease.
I see.
It's not an these patients sometimes have elevated IL-6. But I would just, I mean, if you had a serum on this patient, it'd be really interesting to see if he had a huge VEGF elevation.
Yeah, Bill, you've looked at that before with preeclampsia. I know you have some interest in that, and it's a really hard test to get done.
Yeah, we're lucky that we do have a lab that can do it, because we have our research lab with Dr. Reiser, who obviously runs a lot of SUPAR tests, but he's able to get us a lot of testing. So we've done a couple case series and studies with looking at VEGF and SFLT, et cetera, and preeclampsia, which it's been a good collaboration.
Yeah, and to be honest, I mean, this VEGF, anti-VEGF, it's always confusing to me. And SFLT, and I also have to think through it, ABC, which it is. I know certainly the endothelial inhibitors are anti-VEGF, is associated with endotheliosis, and it looks just like preeclampsia and non-pregnancy. Is that right, Bill?
That's exactly right. Yeah.
Yeah. So
Roger, so what's
yes.
the final diagnosis kidney-wise here?
I think that, well, I mean, short of anything else, I think he's a sick individual with ATN. And
well, what about the plasma cells? You don't see that in ATN.
I don't know, Mario. I know that, I went and looked up Castleman's disease in the kidney, and there's like 6 or 7 cases, and it wasn't like you see big
the reason I'm bringing it up, Roger, I'm sorry to interrupt you, but now that you're older, and happy birthday, by the way, I attached the Chinese paper for the audience on the renal manifestations of Castleman's disease. And interestingly, most of the involvement is glomerular. Only about anywhere between 6 to 10% is interstitial. But I'm still wondering about the role of the viruses, particularly herpes. The patient did receive a cyclovir. So true and unrelated.
No, not necessarily. I think everything you brought up is a possibility. I mean, ATN is just a pattern of injury. We don't know if that's because he was sick or because of some exposure to a virus or some interstitial other process related to antibiotics or acyclovir or plasma cells or whatever. I think you're absolutely right. We shouldn't stop necessarily with ATN being ATN, because again, it's a pattern of injury.
Sure.
You can have many
And the other
pathophysiology.
thing,
So I think it's a really good point. I'm not trying to trivialize your point.
And along the lines of what Dr. Glassock mentioned on the role of the EM, if we would have seen tubular reticular inclusions, we would have thought more in favor of a viral process as a interferon footprint.
Exactly, as the driving force behind this. I mean, certainly he had very high viral loads. I'm not really aware of a herpes virus related renal lesion, but I'm sure there is one.
Roger, as he opened up, did he develop proteinuria?
Bill, I don't remember.
Okay. Pravir, do you?
No, I think he opened up. There was a repeat UA. It wasn't quantified, but there was no dipstick protein.
Okay. That certainly goes against glomerular proteinuria.
Yeah, exactly. Well, the good news is he got a diagnosis these are hard we rely upon tests and tests and tests, and sometimes you have to make a clinical diagnosis, and it becomes harder and harder the more test dependent we get to make that call. It was obviously very hard for hematology to make that call. It may seem easy in retrospect, but clearly that's the case. Sometimes you just got to make a call. Unfortunately, they made the call, and I don't know what the light bulb moment was for hematology, but and maybe in retrospect they feel like it's a duh, but it clearly was not a duh, because it was very difficult to make. And just fortunately, this guy's doing really, really well. And would have clearly died from this had it gone on much longer. I mean, he easily could have had a terrible CNS bleed just from his thrombocytopenia and died. Well, I'm going to wrap this up. Thanks, everybody, for joining us. Today's CME activity code is 486227. If you're not on our mailing list and want to get on it, just send one of us an email. We'll put you on. Thanks, everybody, showing up. I think we had over 60 people today, which is it's been a while, so we're glad to have everybody here. And we'll be on next week. We'll be on a lot in the next few weeks because of interview time, interview sessions. So we'll see you next week. And until then, everybody stay safe.